Now for the final part of this talk on pressure sores, we're going to look at how we assess the degree of risk. Some people are at greater risk of developing pressure sores than others. And we're going to look at why is this so? Why are some people at greater risk of developing sores than others? What are the risk factors that we can look for? Because if we can identify the risk factors in a particular individual, as we assess a particular individual, we can assess how likely it is or how predisposed that individual is to developing pressure sores. And we can plan a preventative strategy according to the degree of risk. So if the degree of risk is high, we're going to have to be a lot more careful in preventing pressure sores, in regular turning and all the other things that we do to prevent them, than if the risk is relatively low. So how do we do this? Well, there's several assessment scores or assessment tools available. None of them are perfect, but the first one is called the Norton score, and it goes right back to the original research that was done by Norton in 1962. So it first came out in 1962, so over 25 years ago now. So let's think about that first of all. So we're looking at assessment of risk. What is the level of risk that any individual has of developing a pressure sore? To determine this, we should use an assessment tool, a method of deciding what the risk is. And the first one we're going to look at is the Norton scale, which goes right back to 1962. The first one that certainly I am aware of. Now the Norton scale just looks at 5 categories about the person. It looks at physical condition first of all. What is the patient's physical condition? So if the patient's physical condition is overall fairly good, you give them a mark of 4. If you only describe it as fair, you give it 3. If the patient's physical condition is poor, you give them a 2. And if it's very bad, you give them a 1. Now clearly these are all fairly subjective assessments on your behalf. So you've got to decide what your assessment of the patient's physical condition is and give them a mark accordingly. So for example, if you would say the physical condition is only fair, they would get a 3 for that. So you would mark them as a 3 on overall physical condition. The next thing you need to assess on the Norton scale is mental condition. What is the patient's mental condition? If they're fully alert and with it, they get a 4. If they're apathetic, a bit depressed, they get a 3. If they're confused, they get a 2. And if they're stuporosed, not with it at all, they get a 1. So if your patient was fairly, well, whatever it is, let's say they were a bit apathetic, a bit depressed, again, they get a 3 for that. So your assessment, again, it's fairly subjective on your behalf. It depends on your professional assessment, really, of the patient's mental condition and which category you will put it into. The third category the Norton scale looks at is the overall activity of the patient. How mobile are they? If they're fully ambulant and able to move around, they get a 4. If they can only walk with help, they get a 3. If they're chair-bound, can just get around in a chair, they get a 2. And if they're limited to bed, they get a 1. So again, assess how mobile, how active the patient is, and give them a score accordingly. So if this patient, for example, was chair-bound, for that they'd get a 2. Now the next category on the Norton scale is mobility. And of course, the obvious question is, well, what's the difference between mobility and activity? And this isn't entirely clear to me either. But nevertheless, to fulfill the criteria of the Norton scale, you'd have to decide whether the patient is fully mobile, mobility is slightly limited, very limited, or whether the patient is completely immobile. So again, you can score that. And if we say this particular patient has slightly limited mobility, then if there's slightly limited mobility, we'd give them a 3 for that. And the final factor considered by the Norton scale is certainly very important in indicating whether pressure sores are likely to occur, whether the patient is incontinent or not. So if the patient's not incontinent at all, they get a 4. If they're occasionally incontinent, they get a 3. If they're usually incontinent of urine only, they get a 2. And if they're doubly incontinent, they get a 1. So again, you would make an assessment of the level of incontinence. So if this patient, for example, is occasionally incontinent, then for that they would get a 3. So we've assessed the patient's condition under physical condition, mental condition, activity, mobility and incontinence, and we've given each category, we've scored each category with a number. So what do we do with these numbers once we've assessed them? Well, we score each patient 1 to 4 under each of the headings A to E. That was physical condition, mental condition, activity, mobility and incontinence. And we add up these scores. So for example, my hypothetical patient, for physical condition I said that was fair, so I gave them a 3. Mental condition, they were a bit depressed, a bit apathetic, so I gave them a 3 for that as well. Activity, we said they were limited to sitting in a chair, so we gave them a 2 for that. Mobility, I've got as slightly limited because they could get around in the chair in this particular hypothetical case. And incontinent, I said they were occasionally incontinent. So they're the scores I've got. We add those up. So that's 3, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 9, 6, 12, 6, 14. Get that right. It's 14, that's right, isn't it? 6 and 6 is 12, 13, 14. So my particular patient got a score of 14. And we see here that a score of 16 or less indicates that the patient is at risk and preventative care is necessary. So this patient, because they've got a score of 14, is at risk. Clearly, the lower the score, the greater the risk. If the score is 16 or above, the risk is significantly less or little or no risk. So the lower the score, the greater at risk the individual patient is. And the third point here, assessment is not a once-only process. As patients remain under our care, they may deteriorate or they may improve, and the level of risk may change. So we need to reassess the patient from time to time. Now, the Norton score was the first to come out. It has its limitations, as we've seen, but it's not too bad an indicator. But it does tend to slightly underpredict the risk. So it tends to slightly underpredict the risk of pressure sores. But it's a fairly useful tool. It was the first one. And it's a lot better than not using any assessment tool at all. So the Norton scale, as you may well want to include it in your patient's assessment. So it's not a bad predictor, but as we said, it does tend to underpredict. It doesn't really take account of intrinsic and extrinsic factors properly, such as, for example, nutritional status and body build. It doesn't take into account diseases either. So there are other scales which we'll look at in a minute which do take these more into account. And the next risk assessment tool we'll look at is called the Douglas Pressure Sore Risk Indicator. So the Douglas score looks at certain risk factors, and it looks at nutritional status and the hemoglobin of the patient, going on to look at activity, incontinence, pain, state of the skin, mental state. So it's looking at 6 factors. And the first, as we see here, nutritional state and hemoglobin. If the diet is well balanced, the patient is well nourished, they get a 4. If the diet is inadequate, they get a 3. If the patient is not on any diet at all and only on fluids, they get a 2. If they're on artificial feeding of some sort, they get a 1. And if they've got a hemoglobin below 10, they also get a 1 for that category, despite what the diet might be. So again, score your patient 1 to 4 on nutritional status and hemoglobin. The Douglas score takes into account the activity of the patient. Fully mobile patients receive a 4, walking with difficulty a 3, chair-bound a 2, and bed-fast a 1. Pretty well the same as the Norton scale in that category. It also takes into account incontinence. So if the patient is fully continent, they get a 4. If they're occasionally incontinent, they get a 3. If they're incontinent of urine, they will get a 2. And if they're doubly incontinent, you score them on a 1. Now Douglas takes into account the presence or absence of pain, because pain can reduce mobility, is presumably the rationale for this. So if the patients are pain-free, they get a 4. If they're free of pain for most of the time, they get a 3. If they have pain periodically, they get a 2. And of course, the difference between these two is pretty subjective, really. It's not really very scientific, this. If they have periodic pain, they get a 2. Pain only when they move, they score them as a 1. And if they're in continual pain or discomfort, they get a 0 mark for that. Skin state. This needs to be visualised and assessed. If the skin is intact all over, they get a 4. If there's any dry redness or thinning of the skin, they get a 3. If the superficial breaks in the skin are already present, they get a 2. And if there's already a cavity present, they get a 1 for skin state. So the next factor the Douglas score takes into account is the mental state of the patient. If they're fully alert and with it, they get a 4. If they're apathetic or depressed, they get a 3. If they're stuporosed or sedated, they get a 2. If they're uncooperative, they get a 1. Although quite what uncooperative means might be difficult to say. And if they're comatose, they certainly get a 0 for that. So the Douglas score has looked at nutritional status stroke hemoglobin, level of activity, presence or absence of incontinence, presence or absence of pain, state of the skin, and mental state. 6 factors. But it also looks at some special risk factors in addition to these 6 main categories. So Douglas identifies special risk factors, and the rule here is that you deduct 2 points from the score if any of these factors are present. So you deduct 2 if the patient is on steroid therapy, because that will be steroids are immunosuppressing, therefore prevent wound healing. Deduct 2 if the patient is diabetic, because they're more prone to infections. Deduct 2 if the patient is on cytotoxic therapy for malignant disease, because the cells are unable to divide. And deduct 2 if the patient has dyspnea, difficulty in breathing, because that will mean the tissues may be relatively hypoxic. So if any of these special risk factors are present in your patient, you deduct 2 for each. And if 2 of these risk factors, so for example if a patient is on steroids and diabetic, you deduct a total of 4 in that case. So deduct 2 for each of the special risk factors. So what do we do with this information? Well, we give them a score. So suppose a patient has an inadequate diet. They will get a 3 for that. Suppose their activity is walks with difficulty. They will get a 3 for that. In terms of incontinence, let's imagine they're incontinent of urine, so we'll give them a 2 for that. If they have pain from time to time, periodic pain, we'll give them a 2 for that. If the skin state is currently intact, for example, they'll get a 4. And mental states, let's say they're a bit depressed, a bit apathetic, they will get a 3 for that. And we can add these up. So that's 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Total score of 17. Just check that. 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. 17, yep. So 17 is the total score. But let's presume this patient was diabetic, So if they're diabetic, we have to take away 2 for special risk factors. So it's 17 minus 2, giving us an overall score of 15. So the patient's score will be 15. And a score of 18 or below indicates that the patient is at risk in this particular assessment tool in the Douglas score. So this patient with a score of 15 would be at risk. So to summarise this on the notes, each factor in the categories are assessed and scored. The total score is added up to give the risk factor, taking into account deductions for any special risk factors. And a score of 18 or below in this one. 18 or below indicates the patient is at risk. Therefore, preventative care is necessary or pressure sores will occur. Assess the patient regularly, of course, as the condition changes. Now, if anything, the Douglas score tends to over-predict. We said the Norton scale perhaps tends to under-predict. If anything, the Douglas score tends to slightly over-predict the risk, which is okay, probably errs on the side of caution. So I think you're getting the message that we're not saying any of these scales, assessment tools are a definitive assessment tool, but they are the sort of things you need to pick up on in your assessment, the sort of things you need to be alert to. So if you decided to use a Douglas scale-based assessment tool, you might come up with something like this in your patient assessment notes. So we've got the categories along the top, the special risk factors here. As we said, deduct 2 for each: steroid therapy, diabetes, cytotoxic therapy and dyspnea. Then you could simply, as you make your assessment of your patient, circle the relevant, whatever it was, the relevant degree of risk. Add them all up and then deduct 2 if any of the special specified risk factors were present. Once you've got this in your assessment documentation, very easy to use actually. Now the third and final rating scale we're going to look at, the third and final assessment tool, is called the Waterloo scale. And this takes into account more factors than the Norton and the Douglas. Now, whereas the Norton and the Douglas scale, the risk was increased with a lower score, in other words, you wanted to get as high a score as possible to minimise the risk. With the Waterloo score, it's the other way round. A higher score indicates greater risk. So the Norton and the Douglas lower score indicated greater risk. The Waterloo scale, a higher score indicates greater risk. And it takes into account 10 factors, 10 groups of risk factors. Now, again, there's a fair degree of your professional discretion required on what numbers you actually give. But the important thing is the categories that do give rise to increased risk to help us, again, in our assessment of risk, therefore on the amount of preventative care and type of preventative care which is going to be necessary for the individual patient. And really the whole point of this is to individualise care, specific care to a specific individual patient. So let's run through now the 10 factors that the Waterloo scale considers important. And the first category is body build and weight and height, weight or height. So a patient with average body build and average weight will get a score of 0. An overweight individual will get a score of 1. If a person was frankly obese, they would get a score of 2. But if they were below average, they would get a score of 3. And you probably remember we discussed this. Obese people are heavier, therefore there's greater pressure. But if someone is very below weight, then the bony prominences are protected by less subcutaneous tissue. Therefore, pressure sores, in this case, would appear to be even more likely than if someone is obese, according to Waterloo. So the Waterloo scale says quite a lot about the appearance of the skin of at-risk areas, the skin where there are pressure points that we discussed earlier on in the talk. So if the appearance of the skin at pressure points is healthy, they get a 0. If it's got a tissue paper-like appearance, they get a 1. If it's excessively dry, they get a 1. If it's edematous, they get a 1. If it's clammy with a pyrexial patient, they get a 1. If the skin discoloration over pressure points, they get a 2. And if the skin is broken at all, they get a 3 for the appearance of the skin over the pressure points. The Waterloo scale also takes into account the gender of the patient and the age of the patient. So males get a 1, females get a 2. And I don't know why there's a difference there, to tell you the truth, but that is part of the Waterloo scale. And the older the patient, the greater the risk. So the older the patient, the greater Waterloo assesses the risk. Now, the Waterloo scale recognises the risk of special risk factors that can cause tissue malnutrition. Special risk factors which can cause embarrassment and malnutrition of the tissues. Now, the first one that is recognised is terminal cathexia, where there's the extreme emaciation and weight loss that's associated with the terminal stages of cancers and malignant diseases. That carries a very high risk of pressure sore formation, an 8. Cardiac failure carries a risk of 5, presumably because of the venous congestion and the tissue edema that will occur as a result of that, and the inability of the blood to move freely through the tissues, delivering oxygen and getting rid of waste products. Peripheral vascular disease can cause ischemia due to the reduced lumen of the arteries. Less blood gets through, therefore less nutrition gets through, less oxygen gets through, therefore the tissues become relatively malnourished. Anemia is reduced oxygen carrying capacity of the blood. Therefore, if the patient's anemic, the blood which is getting through to the tissues carries less oxygen. And the situation is similar in someone who smokes. There's carboxyhemoglobin in the blood, therefore the blood can carry less oxygen. And as well as that, smokers tend to excrete a lot of vitamin C, so the tissues don't heal up as well. So assessment of special risk factors leading to tissue malnutrition. Next factor Waterloo considers is continence. So if the patient is completely continent or catheterized, they score 0. If they're occasionally incontinent, they score 1. If they're catheterized but they're incontinent of feces, they get a 2. And if they're doubly incontinent, they get a 3. Mobility is taken into account in the following way. Patient that is fully mobile scores a 0. If they're restless and fidgety, they get a 1. Apathetic or depressed, a 2. Restricted mobility, a 3. If the patients don't move around very much at all or are in traction, for orthopaedic conditions, they get a 4. And if they're chair-bound, they get a 5. And presumably, bed-bound, they would get a 5 as well, although the scale doesn't actually say that. Appetite is taken into account. An average healthy appetite scores 0. Poor appetite scores 1. Patients being fed with a nasogastric tube or only on fluids, they score 2. And if they're nil by mouth or anorexic and not eating for other reasons, they score a 3. Neurological defects. So if the patient's diabetic, and I know that's not a neurological defect, but nevertheless the score includes it here. The diabetic, multiple sclerosis, or they've had a cerebrovascular accident, or they've got motory or sensory paraplegia, like paralysis below the waist, then they get a score between 4 and 6. Now, that's all the information the scale gives us. So the more severe you monitor the neurological deficits of your patient, the higher you have to give the score in that category. Waterloo takes into account the fact that the patient may have had surgery or be traumatised. So, for example, with orthopaedic conditions, if there is a below-waist spinal anaesthesia, that's considered to increase the risk by 5. And if the patient's on a table for 2 hours or more, that also increases the risk of pressure sores developing post-operatively this time. Medication is also taken into account. The patients are on steroids, cytotoxics or high doses of anti-inflammatories. Then you can add up to 4 points depending on how much you consider that drug to increase the risk. So a lot of subjectivity involved here in the Waterloo scale. So taking into account build or weight of the patient, appearance of the skin, gender and age of the patient, special risks which may lead to tissue malnutrition, continence or incontinence, mobility or immobility, appetite, neurological defects, major surgery or trauma, and medication. Taking those 10 factors into account, and you score them the same way we have done before, and you end up with a total of the scores, and then you grade the risk according to these criteria.